Bismillahirrahmanirrahim. The control of insulin secretion is discussed in this video. The blood glucose concentration is the main factor that control the insulin secretion. Increased blood glucose directly stimulates the pancreatic beta cell to release insulin. Other nutrients such as blood amino acid, leucine, isoleucine, valine also stimulate insulin secretion, especially after a protein-rich meal. Free fatty acids in the blood can also modulate the insulin release. Then there are hormonal and neural factors involved, such as gastrointestinal hormone, GIP, gastrin, cholecystokinin, secretin. They all enhance insulin release after meal. Parasympathetic nervous system stimulation via acetylcholine. It also increases insulin secretion. Beta adrenergic stimulation enhances, while alpha adrenergic system stimulation, it will suppress the insulin release. Other hormones like glucagon, growth hormone, and cortisol can indirectly increase insulin secretion by raising blood glucose or amino acid level. Then there are inhibitory factors such as somatostatin that inhibit insulin secretion. Fasting and decreased blood glucose also reduces the insulin secretion. Leptin can also suppress the insulin secretion. Then there are drugs such as sulfonylurea that are glyburide and tolbutamide. They stimulate the insulin secretion by closing the ATP sensitive potassium channels. Insulin resistance and obesity are associated with high insulin secretion due to chronic metabolic demand. So this insulin release is a multifactorial process influenced by glucose, amino acid, fatty acid, hormone, and various neural signals. So insulin secretion is stimulated by increased blood sugar. So the baseline secretion is about 25 nanogram per minute per kilogram of the body weight insulin secretion, and this occur with the fasting blood glucose of 80 to 90 milligram per 100 ml of blood. This low rate has little physiological activity, just enough to maintain basal metabolic balance. Then there is effect of sudden rise in the blood glucose. When blood glucose level rises 2 to 3 times above normal, insulin secretion increases in two distinct phases. So in phase 1, there is rapid release of the insulin within 3 to 5 minutes, and plasma insulin increases almost tenfold within the 3 to 5 minutes. So this is immediate release of preformed insulin. Then this early spike occurred due to rapid release of the preformed insulin that was present in the beta cell. This initial burst is short-lived, and within 5 to 10 minutes, insulin level falls about halfway back towards the baseline. Then there is a sustained release of the insulin that occurs about 15 minutes to 2 to 3 hours. Around 15 minutes after the glucose rise, insulin secretion increases again and it forms a second sustained plateau, and this is due to additional release of preformed insulin. Then this plateau is often higher than the initial peak. It results from additional release of stored insulin and newly synthesis of insulin by activation of beta cell enzyme system. So the key mechanisms that are involved in this biphasic secretion of the insulin. Phase 1, there is immediate release of the glucose, then long-term stabilization of the blood glucose in phase 2. So this concept is described in this graph, the biphasic pattern of plasma insulin secretion. There is a sudden rise in the blood glucose to 2 to 3 times of the normal range. On the x-axis, there is time in the minutes ranging from -10 to 90 minutes, and on the y-axis there is plasma insulin in microunit per ml, ranging from 0 to 100 microunit per milliliter. Before glucose elevation, -10 to 0 minutes, plasma insulin levels are low and around 10 microunit per ml, representing fasting basal secretion. In phase 1, there is a rapid spike. In this phase 1, there is a rapid in 0 to 5 minutes. There is rapid spike uh, in the insulin level that is close to about 90 microunit per ml, and this initial surge is due to release of preformed insulin from the beta cell. After this quick spike, insulin level dropped to around 50 microunit per ml by 10 minutes, and then phase 2 starts. Here there is sustained increase that lasts from 15 minutes to around 90 minutes or 2 hours. So this around 15 minutes, this insulin level begins to rise gradually but steadily, and a new higher level is reached by 60 to 90 minutes as newly synthesized insulin is now secreted in response to continued high glucose. So we can say that there is an early phase, that is fast release of the glucose of the insulin uh, that was stored. So this is early phase or immediate response. Then there is long-term glucose control or late phase, where there is sustained insulin synthesis and release. At 100 milligram per 100 ml, blood glucose insulin secretion is at its basal level. It is at low level. When glucose rises as the blood glucose level exceeds above 100 milligram per 100 ml, insulin secretion rises rapidly. At glucose concentration between 400 to 600 milligram per deciliter, insulin secretion can reach 10 to 25 times the basal rate. And there is a feedback mechanism that this rise in the blood glucose will lead to insulin secretion, and this insulin secretion also increases. Then insulin promotes glucose uptake into the muscle, liver, and adipose tissue and enhance glucose storage. And glycogen in the liver, muscle, and fat in the adipose tissue are stored. And these processes they reduce the blood glucose concentration back towards the normal level. As glucose drops, insulin secretion then decreases, rapidly returning to baseline within 3 to 5 minutes after the blood glucose normalizes. So this negative feedback loop maintains blood glucose level within a normal physiological range, preventing hyperglycemia or hypoglycemia. So the insulin secretion is highly sensitive and dynamic, responding almost instantly to fluctuation in blood glucose to maintain homeostasis. So certain amino acids they act as insulin stimulators, particularly arginine and lysine. They can stimulate insulin secretion. However, this effect is weaker compared to the glucose. And when amino acids are given without an increase in blood sugar, insulin secretion is small. But when amino acids are present along with elevated blood glucose, the glucose-induced insulin secretion doubles. Amino acids amplify the effect of glucose on beta cells. The physiological importance of this mechanism is that the insulin secretion in response to amino acid ensures increased uptake of amino acid into the tissue cells and enhanced protein synthesis inside the cells. This mechanism helps the body properly utilize excess amino acid just as insulin aids in carbohydrate storage and use. So amino acid and glucose work synergistically to stimulate insulin secretion, ensuring balanced nutrient storage, both the carbohydrates and protein. Key gastrointestinal hormones that are responsible for increased insulin secretion include gastrin, secretin, cholecystokinin, glucagon-like peptide 1, glucose-dependent insulinotropic peptide, and GLP-1 and GIP are the most potent and are collectively referred to as incretin. So these incretins enhance the insulin release from pancreatic beta cell in response to rising blood glucose. They also inhibit glucagon secretion from pancreatic alpha cell. This thus these incretin fine-tune the glucose regulation during and after the meal. These hormones are secreted by GI tract after food intake. They cause an anticipatory rise in blood insulin before significant absorption of glucose and amino acid occur. This prepares the body to efficiently handle the upcoming post-meal glucose load. And similar to amino acid, incretin amplify the insulin response when glucose level rise, often doubling the secretion rate. So they have got a therapeutic relevance that the modern anti-diabetic drugs such as GLP-1 analogs or DPP-4 inhibitors mimic or enhance incretin activity to boost insulin release and improve blood glucose control. There is influence of other hormones on the insulin secretion. The hormone that potentiate or increase the insulin secretions are glucagon, growth hormone, cortisol, progesterone, and estrogen. The prolonged excess secretion of this hormone overstimulate beta cells in the islets of Langerhans and lead to beta cell exhaustion and increase the risk of diabetes mellitus. So, examples of hormonal disorders that lead to diabetes are acromegaly, that may be associated with growth hormone uh, secreting tumor that lead to chronically high growth hormone level that lead to beta cells stress and diabetes risk. Then there is Cushing syndrome that may be associated with excess glucocorticoid or due to glucocorticoid secreting tumor of the adrenal gland, and similar to beta cell overwork, these lead to steroid induced diabetes. Then there is role of autonomic nervous system in the insulin secretion. The parasympathetic stimulation via vagus nerve, it increases insulin secretion during hyperglycemia, while sympathetic stimulation decreases insulin secretion during hypoglycemia to keep blood glucose from dropping too low, increases glucagon secretion to raise blood sugar. And the glucose can be sensed by the nervous system. So the hypothalamus and brainstem neuron act as glucose sensors. The peripheral glucose sensing cells, for example in the liver, also modulate autonomic signals to the pancreas. So the hormones and neural input works together with glucose level to regulate insulin secretion. Chronic hormonal imbalance can overload pancreatic beta cell, increasing the risk of diabetes. Thank you for watching this video. If you have any query, please write in the comment box.